Hello and welcome to today's presentation. This is a continuation of the urinary system. In the first lesson, we looked at the urinary system. Now is the time to start looking at the urinary tract urinary disorders, and one of them is the urinary tract infection. Welcome. So the overview of urinary tract infection. We say that a urinary tract infection is an infection in any part of your urinary system. It could be the kidneys, ureters, bladder, urethra. It's a bacterial infection of the lower urinary tract infection. It comes into two forms. We have cystitis, which is the infection of the bladder, and urethritis, infections of the urethra, most often related to sexually transmitted infection. Remember, urethritis normally happens in males, whereas cystitis commonly happens in females. So there's possible recurrent and resistant bacterial flares during therapy. In males, is typically associated with anatomical or physiological abnormalities, may be abbreviated as UTI. So when you hear of UTI, guys, know that you're talking about urinary tract infections. Wonderful. So here, guy, we have a patient here. A nurse advising patients. So a nurse is providing health teaching to a group of adolescent girls. The focus is on urinary tract infection. One of the girls tells the nurse that she wants to know more about cystitis. Which statement by the nurse is the most appropriate response? This condition can result from irritation and inflammation from sexual activity. This is a serious condition that occurs after intercourse or vaginal cleanses. This condition happens frequently in young women and is not harmful. This is a minor bacterial infection of the bladder that can occur anytime. Okay, guys, give me the response. Send your answers. Great, guys. We say that from Unit 1 that cystitis is the infection of the bladder. Okay? This condition can result from irritation and inflammation from sexual intercourse. Okay? Cystitis is a lower urinary tract infection. One cause in young adolescent women is after their first sexual intercourse. The urinary tract infections occur because of inflammation and local irritation caused by sexual activity. So blood infections can lead to complication and therefore are not minor or harmless. So we should eliminate those options that were presenting as a status as a minor. That is C, D should be eliminated. Bladder or urethral infections is not the result of vaginal cleansing, and that rules out B. And we remain with our answer, which says that cystitis, a condition, can result from irritation and inflammation from sexual activity. A client with a history of chronic cystitis comes to an outpatient clinic with signs and symptoms of this disorder. To prevent cystitis from recurring, the nurse recommends maintaining an acid-ash diet to acidify the urine, thereby decreasing the rate of bacterial multiplication. On this type of diet, the nurse must restrict which beverage? Yes. So for the prune and prune juice and cranberry juice, I think for them at least we are comfortable with them because they ensure an acidic environment that limit multiplication of bacteria. We know coffee is neutral. That's why ED is the correct answer. We have to limit milk because this one normally alkalizes the vaginal media. Okay, so a client on this diet must avoid milk and milk products because these make the urine more alkaline, encouraging bacterial growth and multiplication. Other foods to avoid to this diet include all vegetables except the corn and lentils, all fruits except the cranberries, plums and prunes, and any food containing large amounts of potassium, sodium, calcium, or magnesium. Cranberry and prune juice are encouraged because they acidify the urine. Just as we had indicated, coffee and tea are considered neutral because they don't alter the urine pH. So what's the pathophysiology? We say that this condition results from colonization of vaginal introitus in females or urethra in males occurs. So the organism ascends by way of the urethra into the bladder. Local mechanisms in the bladder breakdown are inhibited, no longer active. Bacteria therefore invade the bladder mucosa and multiply. Bacteria can't be readily eliminated by normal urination. The pathogens resistant to prescribed antimicrobial therapy usually causes bacterial flare-up during treatment. Therefore, recurrent lower UTIs result from reinfection by the same organism or a new pathogen. Okay, so what are the routes of infection in the urinary tract? We're saying that this image shows the routes by which bacteria can invade the urinary tract. Can be either from the ascending, as the reflux from the bladder to the kidney. Yes, bladder to the kidney. Bladder to the kidney. On my right, on my left is a female client, and on my far right is a male client. Okay, so we continue. 2, we could have ascending urethra to bladder. Ascending urethra to bladder, yeah, coming to the bladder. Coming to the bladder, yes. Or from rectum and prostate to the bladder, yeah, on the right. From rectum and from rectum and prostate to the bladder, yeah. Same rectum, yeah. 3, from rectum and cervix to bladder, yeah. From rectum and cervix to the bladder. 4, from bowel to the bladder. From bowel to the bladder. Bowel to the bladder. So ladies and gentlemen, these are some of the routes of infection in the urinary tract. Great. So in summary, that's how it happened. You have the colonization of the urethra, then the uroepithelium epithelium penetration. It ascends to the kidneys, and multiple complication will the one that we have to mention. We have the pyelonephritis and even AKI, acute kidney injury. Okay. What are the causes? We have ascending infections by single gram-negative enteric bacterium, and the most notable gram-negative gram-negative enteric bacterium is the Escherichia coli. we are saying that is the most common. We also have Klebsiella proteus, Enterobacter, Pseudomonas, or Serratia. Another cause we have simultaneous infection from multiple pathogens. And then the third cause we have Neisseria gonorrhoeae or Chlamydia trachomatis. Okay? Great. Chlamydia is so common, such that when you are treating someone of gonorrhea, we have to combine the antibiotics just to take care of it. Very good. Which gland is at the highest risk for developing urinary tract infection? We have a woman who has given birth to 2 children, a man with an indwelling urinary catheter, a man with a past medical history of renal canaliculi, a woman with a well-controlled diabetes mellitus. Yes, thank you. We have to immediately eliminate this one because this one is as a stable patients with stable sugars, stable diabetes, well controlled. Okay. What about a woman who has given vaginal birth to 2 children, and a man with past medical history of renal canaliculi? Past medical history. Ladies and gentlemen, if you compare the three, and according to various research that have been done, it has been found that indwelling catheters, unnecessary catheterization, are one of the major or the leading factor of the hospital-acquired infection, more so the urinary tract infection, making B the correct answer. Okay? So indwelling catheters are considered to be major contributor to those nosocomial infections. Yeah. So any client with an indwelling catheter is at a higher risk for developing urinary tract infection. So a history of previous birth does not necessarily predispose a client to UTI. Clients with a history of renal canaliculi are not necessarily at risk for developing UTI unless the renal canaliculi reoccurs. Clients with diabetes mellitus are at a higher risk for developing urinary tract infection, but this risk can be decreased by maintaining a good control over blood glucose levels. Very good, guys. So this question was testing about risk factors, and we are saying that the risk factors for UTI include natural anatomic variations, inadequate fluid consumption, trauma or invasive procedures, urinary catheter use, and we are saying that this one is one of the most common in cause of nosocomial infection, urinary tract obstructions, vesicoureteral reflex, urinary stasis, immunosuppressive conditions, bowel incontinence, immobility, BPH, use of spermicides or diaphragm, poor hygiene, postmenopausal, immunosuppression, sexual activity, or risk increases with each sexual partner, urinary procedures. If we try to divide, we can be able to categorize these risk factors into iatrogenic drugs, behavioral, anatomic stroke physiological, and genetic. When you look at the iatrogenic causes, we have the spermicides, we have the antibiotic use, indwelling catheter, and we say that indwelling foreign catheter provide an ascending route for perennial bacteria to enter the blood. Our recent antibiotic use normally disrupts the normal bacteria flora at the vaginal introitus, allowing uropathogens, e.g. the E. coli, to colonize. Spermicide, they cause irritations and attachment sites for E. coli. Looking at behavioral. So guys, I want to ask, how many times do you void in a day? What are your voiding patterns? Yes? Frequent or recent sexual intercourse. How often? This one is one of the risk factors of UTI. So voiding dysfunction causes increased post-void residual urine volumes, which allows more time for bacteria proliferation. Frequent or recent sexual intercourse may introduce bacteria in the urinary tract. So it's best advice, once you have an sex, you need to urinate within the 15 minutes, after 15 minutes, before. Okay? Difficult, challenging, but we can try, guys. What about anatomic stroke physiological factors? Here we are talking of the vesico-ureteral reflex. We have the female sex and the pregnancy. All these are risk factors. They increase the risk for developing UTI. So the vesico-ureteral reflex causes urinary retention, okay, like blockage, and allows more time for bacteria growth. The retrograde flow also allows bacteria to ascend to the kidneys. We're saying that females have a short urethra. It's around 4 centimeters compared to 25 centimeters in males, even more. Pregnancy results in progesterone-mediated smooth muscle relaxation to the bladder and ureters, and compression of the ureters by the uterus. So both result in urine retention for increased bacterial growth. Last category is the category for genetic factors predisposing one to developing a UTI. We have familial tendency, susceptible uroepithelial cells, and vaginal mucus properties. So UTI occurrence tends to cluster in families. So susceptible uroepithelial cells secrete less IgA, immunoglobulin A, which is the main humoral defense response at the physiological mucosa. Properties of vaginal mucus may allow E. coli binding and more readily. Okay? Great, guys. Those are the risk factors for UTIs. Thank you. What is the incidence of these UTIs? We are saying that lower UTIs are much more common in females than males. And we have an exception for males, the older adult males. And for females, we are saying is because of the anatomically, they have a shorter, yes, urethra, yeah, 4 centimeters. So access to these inner organs and parts of the urinary system is easier, making it easier for there to be an infection. This is probably because of natural anatomic features to facilitate infection. We say that, saying that more than 50% of women have had at least one UTI in a lifetime. Almost half of the women have had a lifetime UTI infection. Okay, can the ladies in this class confirm that? Okay, you'll be lucky if you've not suffered one. So UTI normally occur most commonly in females between ages 20 to 40. And remember, this is the age where they are sexually active. Okay? Yes. Lower UTIs are common in males younger than age 50. Incidence increases with age. Okay? Thank you so much. What are the complications of UTI? We have damage to the urinary tract lining. We can develop pyelonephritis, and we're going to discuss these conditions in upcoming videos and presentations. We could result in sepsis. We have kidney abscess. We have acute urinary outlet obstructions, recurrent UTI, acute bacterial prostatitis, especially in males. guys. So if you have UTI in males, you may find that they have elevated PSA levels. Okay, great. So guys, which action will be the most appropriate for preventing UTI in elderly female clients? Have the client urinate at least every 6 hours? Are we supposed to urinate at least every 6 hours? No, should be at most 4 hours. That is wrong. It's not so appropriate. Although it helps us remind ourselves that we need to urinate. But the frequency is the problem here. Insert an indwelling urinary catheter. Uh-oh. We talked of the risk factors and we say that indwelling urinary catheter are the major leading causes of nosocomial infection. We try to avoid such. Administer prophylactic antibiotics. Yes, but what? Yes, the elderly have decreased functions, liver functions, kidney functions. We don't want to bombard them with unnecessary medication unless it is very necessary. Instruct the client to avoid tight fitting underwear. Yes, they need to have loose ones, and that will help them because this one will avoid the formation of a worm. We want to discourage the formation of a warm, moist environment because that is what motivates bacterial multiplication. Okay, clients should void whenever they feel the urge, or at least every 4 to 6 hours during the day. An indwelling catheter increases the risk of UTI. Prophylactic antibiotics are typically not used for UTI unless the client has experienced repeated episodes within 1 year. So you can see my client on my far left. On my right, we have the parts of the urinary tract affected and the signs simply. So in the kidneys, we have the pyelonephritis, bladder we have cystitis, and urethra we have urethritis. Yeah, so for urethritis we have the burning with urination. Yes, discharge. On bladder we have pelvic pressure, low abdominal discomfort, frequent painful urination that we refer as the dysuria. We have bladder in urine. For the kidneys, we have upper back and side flank pain, high fever, shaking and chills, nausea and vomiting. Guys, we need to try to associate the urinary tract infections with the region that has been affected. Okay? Great. Thank you so much. Let's look at the assessment. And starting with history, you want to know what is the urine urgency and frequency in this patient. And I find that patients with UTI will always have the frequency will be increased. Okay? Yeah, the urgency will be so soon. Yeah. So bladder cramps or spasms or suprapubic pain, saying that clients with UTI, especially the one with pyelonephritis, are going to have the flank pains. Okay, flank pains. Pruritus as a result of accumulation of wastes, feeling of burning during urination, and this happens especially during urethritis in men. Okay, burning with urination. Okay, guys, nocturia or dysuria, of course, and when you're dealing with the cystitis, yeah, cystitis in the ladies, they are going to experience dysuria, painful, and have urethral discharge, especially in males, and urethritis in males. Okay, we also have lower back or flank pain, malaise, chills, nausea, vomiting, low-grade fever. Okay, all these we'll get them especially in the kidney when the kidneys are involved. Pyelonephritis, feeling of bladder fullness, especially in the cystitis, very good, and also in blood in urine, same to cystitis. There is a warning, guys, that we need to know. Okay, changes in mental status may be the only sign of a UTI in older adults. You may not be able to get these other classic signs, but mental status changes could be the only sign for UTI in an older adult. Thank you so much. What of the physical findings of UTI on physical exam? Of course, this is through inspection, palpation, percussion. Okay. So on inspection, we can proceed, guys. So on physical findings, we say that on inspection, we can see urethral discharge. Now on palpation, we can elicit tenderness over the pelvic area. We can also elicit prostatic tenderness in males. We can also be able to enable the visualization of that cloudy foul smell, of course by light palpation, accompanied by or combined in conjunction with the inspection. We can be able to do that. Hematuria, yeah, inspection, great. So I have a question on my left, and it reads, the nurse is collecting data on a client with UTI. Which statement should the nurse expect the client to make? A client with UTI, I urinate large amounts. Yeah, that's a sign of UTI. I need to urinate frequently. Yeah, that's what you need to do. Hey, this every 4 to 6 hours when you're awake, yeah? Or within 15 minutes before after sex, yeah? My urine smells sweet. Uh-oh. This is for diabetes. I need to urinate urgently. You don't need to do that. So the correct answer is A, B, and C. So we have diagnostic tests. Diagnostic tests for UTIs. So we have microscopic analysis that shows red blood cell count greater than 5 per high power field and a white blood cell count greater than 10 per high power field are suggestive of a lower UTI. When you look at a clean catch analysis, this may show a bacterial count of more than 100,000 per ml, confirming a UTI. Protein levels may be slightly elevated. Urine dipstick testing may be positive for blood, white blood cells, and nitrates. Urine culture with sensitivity testing determines the appropriate microbial drug to be used in treatment. If the patient history and physical examination warrant a blood test or a stained smear of urethral discharge, may rule out sexual transmitted infection. So that was on laboratory. Remember, we are looking at diagnostic tests. So the second diagnostic test is imaging. And you're saying that we have cystourethropy may be performed to evaluate lower urinary tract structures. Also, voiding cystourethropy or excretory urography may demonstrate congenital anomalies that predispose patients to recurrent UTIs. computed topography scanning, that is the CT scan of the abdomen and pelvis, with or without contrast, may be used to detect anatomical and physiological factors associated with complicated UTI. Treatment of urinary tract infection. We have the general, we do the CT bath and warm compresses. In terms of dieting, we do increase fluid intake, that is 2 to 3 liters per day, avoidance of coffee, tea, alcohol, soft drinks that contain citrus and caffeine until the infection clears. On activity, we have no activity restriction, although we encourage the client to void frequently within 15 before post sex. Every 4 to 6 hours when they are awake, they need to void, and that is what needs to be encouraged. So the nurse is teaching an older adult with UTI infections about importance of increasing fluids in the diet. What puts this client at risk for not obtaining sufficient fluid? Diminished liver function? Yeah, they might be having, but does that affect the fluids? Increased production of ADH? Increased production of ADH, this one is found in syndrome of inappropriate antidiuretic hormone secretion. And in that case, they'll be having dilutional hyponatremia. So it may not be the case. I don't agree with A and B. Decreased production of aldosterone. Yeah, decreased aldosterone, but that decreased, do you have decreased? So the question was, what puts this client at a risk for not obtaining sufficient fluids? What do you think of decreased ability to detect thirst? When thirst is not there, and we know that the thirst is controlled by the control center, then the fluid balance may be a problem. So the correct answer is D. So the sensation of thirst diminishes in those who are greater or older than 60 years of age. Hence, fluid intake is decreased. So we have dissolved particles in the intracellular fluid compartment becomes more concentrated. There is no change in bowel function in older adults, nor is there a reduction of ADH and aldosterone as a normal part of age. The nurse is teaching a client with multiple sclerosis about prevention of UTI and renal canaliculi. Which nutritional recommendation by the nurse would be the most likely to reduce the risk of these conditions? Increase fluids 2,500 ml per day and maintain urine acidity by drinking cranberry. Yes, that is correct. Drink large amounts of fluids, especially milk products. Milk products, they normally alkalize the medium, so that one can be able to motivate, this can contribute to bacterial multiplication, so not recommended. Eat foods containing vitamin C, D, E, and drink at least 2 liters of fluid. Okay, so 2,500 is closer to 3,000 of what you want, so with 2,500 becomes a better option compared to C. Eat foods and ingest fluids that cause the urine to be less acidic. It has to be more acidic, okay? So that's why correct answer is A. Treatment of UTI medications. We have antibiotic therapy based on culture and sensitivity of organism, such as doxycycline, ciprofloxacin, levofloxacin, sulfur methoxazole trimethoprim, this is Septrin, okay, azithromycin, and ceftriaxone sodium. Nitrofurantoin microsteps for patients with allergies to Septrin, okay. Nitrofurantoin microsteps, amoxil or cephalexin for UTIs during pregnancy. Okay. Sulfamethoxazole trimethoprim, often in combination with nitrofurantoin microcrystals for continuous microbial prophylaxis for chronic UTIs. We have phenoxyperidine for 1 to 2 days for relief of dysuria, painful micturition. Methenamine for recurrent cystitis in females, especially for patients with antibiotic intolerance or resistance. Vaginal estrogen therapy to reduce the risk of future UTIs for females who are peri, and post-menopausal with recurrent UTIs if there is no contradiction to estrogen therapy. We have Knasberry product prophylaxis to reduce the risk for future UTIs. Okay? Surgery may be performed for UTIs, and this case we normally term it as extracorporeal shock wave, lithotripsy, or endoscopic, percutaneous, or open surgery in cases of recurrent infections from infected renal canal chyli, chronic prostatitis, or structural abnormalities. Nursing consideration as part of nursing interventions. We say we collect urine specimen appropriately, obtain clean catch urine specimen as indicated, assist the patient in collecting clean catch specimen if necessary. We need to administer drug therapy. We need to give sulfamethoxazole trimethoprim with 8 ounces of water. This is equivalent to 240 ml. You give prescribed antimicrobial agent for specified period. Encourage increased oral fluid intake unless contraindicated. Urge the patient to avoid bladder irritants such as coffee, tea, alcohol, beverages that contain caffeine and citrus. Encourage frequent voiding and emptying of the bladder. Assist with perineal care and hygiene. Use cities baths and warm compresses as needed. You do monitoring, and in monitoring, you're monitoring the pain level and effectiveness of intervention using the OPQRST, intake and output, urine characteristics, voiding patterns, vital signs, adverse effects of microbial therapy, associated nursing procedures. We need to do a clean catch urine specimen collection assigned female at birth, clean catch midstream urine specimen collections assigned male at birth, intake and output measurement, nutritional screening, oral drug administration, pain assessment, pain management, perineal care for the female client, perineal care also for the male client, postoperative, preoperative, safe medication administration practices, and cities both. Guys, a clean catch urine sample. A clean catch is a method of collecting a urine sample to be tested. The clean catch urine method is used to prevent germs from the penis or the vagina from getting into a urine sample. That's why we talk of a clean catch. Saying that the nurse is teaching a female client with a history of multiple UTIs about prevention, which statements indicate the client understands the teaching. This one is a female, you can be sure. This is why they have already indicated it. Female. I should wipe from back to front. No, it should be front to back. Okay, ladies? Great. I should take a tap bath at least 3 times per day. Tap bath with UTI? you need a shower instead, okay? I should take at least 1000 milligrams of vitamin C each day. Okay, this one will help in acidification of urine, which inhibits bacterial growth. Okay, so we can keep this one for consideration. I should empty my bladder after a meal. Yeah, but that's not enough. You need to do it more frequent. You need to empty the bladder frequently. You need to do it before and after sex. You need to do it every 4 to 6 hours when you're awake. So the only answer remaining is C, and this one is important in acidification. So the client demonstrates understanding of teaching when she states that she will take vitamin C each day, increasing vitamin C intake to at least 1000 milligrams per day helps acidify the urine, decreasing the amount of bacteria that can grow. The client should wipe from front to back to avoid introducing bacteria from the anal area to the urethra. The client should shower, not bathe, okay, to minimize amount of bacteria that can enter the urethra. The client should increase her fluid intake and void every 2 to 3 hours and completely empty her bladder. It's not sufficient to empty the bladder only after eating a meal. So holding urine in the bladder can cause bladder to become distended and places the client at further risk for UTIs. Very good, guys. A woman with cystitis is to take a 10-day prescription of an antibiotic. The client asks the nurse if she can continue to have sexual intercourse. The nurse will tell the client that remember, cystitis is a UTI and what is affected here? The urethra. Okay? Avoid intercourse until you have completed antibiotic therapy, then limit intercourse to once a week. Not therapeutic. Limit intercourse to once a day early in the morning after your bladder has rested. I don't get the concept. You can have intercourse as long as you wish, but make sure your partner uses a condom. Is this untransmittable? You can't infect someone. As long as you are comfortable, you can have intercourse as often as you wish, but be sure to urinate within 15 minutes after intercourse. C. Intercourse is not contraindicated with cystitis. Voiding immediately after intercourse flushes bacteria from the urethra, which should help prevent recurrence for the client. There is no reason to wait until the antibiotic therapy is completed to have intercourse. There is no reason to limit frequency of intercourse. A condom does not prevent cystitis because cystitis results from introduction of client's own organisms, usually Escherichia coli, into the urethra. A male partner cannot acquire cystitis from a woman with cystitis. So guys, patients need our teaching. We need to include family and caregiver in our teaching when possible, when appropriate. Provide information according to their individual communication and learning needs. Be sure to cover the following. You need to discover diagnostic testing and treatment, including the need to complete the entire course of antimicrobial agent to eradicate the infection, even though symptoms typically resolve within 3 days after starting drug therapy. The fact that 25% of women with UTI experience a second UTI within 6 months, and that 50% develop UTI again sometimes during their lifetime. Prescribed drug therapy regimen, including drug names, dosages, frequency, expected results, schedule of administration, and duration of therapy. Special consideration for prescribed drugs as applicable include need to take sulfamethoxazole trimethoprim with large amount of water. We said 240 ml. The fact that nitrofurantoin microsteels may turn urine dark yellow or brown. Advice effects associated with microbial therapy such as photosensitivity with sulfamethoxazole trimethoprim. Comfort measures such as warm cities bath and compresses over the bladder. Proper perineal hygiene care measures, wiping from front to back and avoiding feminine hygiene sprays and douches. Importance of emptying the bladder at least every 4 hours while awake and immediately before and after sexual intercourse. Need to refrain from sexual intercourse until symptoms resolve. Need to wear cotton underwear. Use tampons during menstruation and shower instead of taking a bath for females. Measures to prevent recurrence, such as not postponing voiding and increasing fluid intake. Signs and symptoms of recurrence and need to notify the practitioner if infection recurs. Discharge planning. Participate as part of multidisciplinary team to coordinate discharge planning efforts. The team may include a bedside nurse, a case manager, urologist, and a physician. Assess patients and family understanding of the diagnosis, treatment, follow-up, warning sign for those who seek medical attention. Identify patients' formal and informal supports. Identify patients and families' goals, preferences, comprehension, concerns about discharge. Confirm arrangement for transportation to initial follow-up appointments. Provide a list of prescribed drugs, including each drug's dosage, prescribed schedules, adverse reaction to report to the practitioner. Provide the patient and family or caregiver as needed with written information on the drugs that their patient should take after discharge. The patient's clinical record, including who was involved in the discharge planning and teaching, their understanding of their teaching provided, and any need of follow-up teaching. Okay? You need to assess the patient's and family understanding of each prescribed drug, including their dosage, administration, expected result, duration, possible adverse effects. Assess patient's ability to obtain medication. Identify the party responsible for obtaining medication. Instruct the patient to provide a list of medication to the practitioner who will be caring for the patients after discharge. To update information when the physician discontinues medication, changes doses, or adds new medication, including the over-the-counter drugs, and to carry a medication list that contains all this information all the time in the event of an emergency. Also ensure that the patient and caregiver receive medical contact information. Ensure that their parent and caregivers receive a copy of discharge instruction and their copy is placed in the patient's medical record. Assess the patient's and the family understanding of teaching using that teach back demonstration when possible. And lastly, you need to document the discharge planning evaluation in the patient's clinical record, including who was involved in the discharge, teaching, the understanding of the teaching provided, and any need for follow-up. Up to this time, guys, thank you so much. We come to the end of the urinary tract infection lecture. Thank you so much for watching. you can click and subscribe, and remember to like the video, subscribe, in order to be notified of other new videos once they have been published. Thank you so much and have a good time.